Okay, is everybody ready? Today we remove the final reason Kentucky critics have for not supporting the Affordable Care Act. Throughout the conception and implementation of this transformative initiative, critics have come up with reasons to oppose and undercut a program that has dramatically expanded access to quality health care for all of our people. As fast and as thoroughly as we've shot down each objection, they've moved on to another one. First, critics said that the ACA wouldn't pass Congress. It did. Then they said it was unconstitutional. The highest court in the land ruled that it wasn't. Then they said President Obama was too unpopular in Kentucky for leaders here to embrace it. Well, I recognized this historic opportunity to help Kentuckians, and I seized on it as fast as I could. Then they said there wasn't a demand for health care reform in Kentucky. Well, over 500,000 Kentuckians proved them wrong. Then they said the Kentucky implementation of the ACA, what we call Connect, wouldn't work. Obviously, it has. Finally, as their last objections, critics say, well, the ACA and Connect might be huge successes, but we can't afford one of the key pieces, the expansion of Medicaid to include the working poor. Well, today, in conclusive fashion, we bury that objection under an avalanche of facts that demonstrate to the satisfaction of anyone and everyone with an open mind that Kentucky can indeed afford to take care of its people. In fact, we can't afford not to do so. Now, I know that some officials were sincerely concerned about Kentucky's ability to pay for the Medicaid expansion long term. I was too. That's why before I made that decision in 2013, I sought advice from the preeminent actuarial firm PricewaterhouseCoopers and the University of Louisville's Urban Studies Institute. These independent groups concluded that expanding Medicaid would inject $15.6 billion into Kentucky's economy over 8 years, create almost 17,000 jobs, turn costly federal mandates into an $800 million positive budget impact, and protect Kentucky hospitals from the impact of cuts in indigent care funding. So, on that basis, we went forward. But those numbers were only a forecast, and I remained intensely interested in whether the performance would back up the optimism. So the Kentucky Cabinet for Health and Family Services hired Deloitte Consulting, an international recognized accounting and consulting firm, and brought back U of L's Urban Studies Institute. After a full year of actual performance and gathering actual data, we wanted an analysis of Medicaid expansion after that first year, and to project those findings through fiscal year 2021. Kentucky is the first state, as far as we know, who has taken such a look. Today, I want to report on the results of this independent fiscal analysis of the 2014 Medicaid expansion experience. First, it's important to give a little context. Many people don't realize that historically, Medicaid has focused on providing care only for certain groups among the poor: the elderly, the disabled, children, pregnant women, and to a lesser extent, some very low-income parents. Simply having an income beneath the federal poverty level did not guarantee access to Medicaid. But my decision to expand Medicaid eligibility in Kentucky changed that, extending coverage to people earning up to 138% of the federal poverty level. These are primarily families with low incomes or childless adults who don't have health coverage because they make too much to qualify for so-called traditional Medicaid, their employers don't provide affordable insurance, and they can't afford to buy individual plans on the open market. And there were many of our fellow Kentuckians who fit that description. In calendar year 2014, Kentucky added 375,000 Kentuckians to Medicaid through the expansion program. Also signed up were an additional 17,000 Kentuckians who were eligible under the traditional Medicaid criteria but had not previously enrolled for various reasons. Coverage for expanded Medicaid began January 2014. What's been the results? First, let's talk about jobs. The 2013 report predicted that Medicaid expansion would lead to about 7,600 new jobs in healthcare and related fields in its first year, as providers expanded to provide all that additional care. The actual figure, much higher. In 2014, actually, more than 12,000 jobs were created as a result of Medicaid expansion, including more than 5,400 health sector jobs. The 2013 report predicted that almost 17,000 jobs would be created by 2021. However, the Deloitte report, after taking actual numbers from the first year, now estimates that by 2021, that number will not be 17,000 jobs. It's expected to grow to more than 40,000 new jobs, with an average annual salary of $41,000. Many of these jobs will be in the core healthcare professions like nurses, pharmacies, doctors, other providers in the network. But these core jobs are also going to create additional jobs for accountants, data analysts, property managers, and many others. And all of these new employees purchase goods and services throughout Kentucky's economy at their local grocery stores, restaurants, retail establishments. So the combined effects of these added jobs will have a significant impact on our families and communities all across Kentucky. Now, a second finding of this new report has to do with the impact on Kentucky's economy. It's a big number, much larger than the $15.6 billion estimate in the first report. With the combined effect of the new jobs, federal Medicaid funding flowing to the state, associated health care spending, and savings realized by state and local governments, the expansion's net economic impact to Kentucky is estimated at $30 billion over 8 years. Thirdly, state and local governments will also see a huge positive direct fiscal impact as a result of this expansion. Now, this speaks directly to critics' concerns about affording the Medicaid expansion. This answers the question, can we afford it? According to the analysis, over the 8 years from fiscal year 14 to fiscal year 21, the net impact is estimated at a positive $819.6 million. That's actually an increase from the $802.4 million figure estimated in 2013. Now, a lot of things go into calculating that figure. The first impact are huge increases in tax revenues, income taxes, sales taxes, and occupational and payroll taxes. Revenues increase as jobs are created and more care is provided. The second impact is that under the Affordable Care Act, we can and have transferred to the federal government costs within the Medicaid program that have traditionally been assigned to the states, dramatically reducing the state's share of payment for certain Medicaid groups. These include special eligibility categories, such as some women covered under a breast and cervical cancer screening program, adults in nursing facilities, and people previously qualified under KTAP. A third impact includes reductions to general fund allegations to certain agencies because services that we once provided are now being picked up by Medicaid. These include health care for prisoners in certain situations, mental health and substance use treatment for certain members of the population, and services at local health departments. A fourth impact involves K-CHIP, which costs less now because the federal match rate has increased to 100%. A fifth impact comes because the state share of payments to reimburse hospitals for providing uncompensated care, also known as the disproportionate share hospital payments, or DSH, will begin decreasing in fiscal year 17. And finally, a sixth impact included in that total is a negative fiscal impact, often cited by critics. At some point, the state has to start paying a match toward Medicaid expansion. Right now, the federal government is now picking up 100% of the cost. In the fourth fiscal year, a small match comes into play, and that match gradually increases, peaking at 10% at the end of the 8-year period. But let me reiterate, the $819.6 million positive impact takes that match into account all the way to 2021. It's also important to point out that if we had not expanded Medicaid, Kentucky would still have incurred about $100 million in additional cost out of general funds, not to mention the millions of dollars in additional penalties that would have hit Kentucky employers. We avoided those because we chose expansion. So that's an important thing that people need to understand. Not only is there a very real net positive impact from expanding, but if we had chosen not to expand, it would have required an infusion of an additional $100 million from our general fund into the regular Medicaid budget. That's why we see many of those with a stake in healthcare, in the healthcare industry, in non-expansion states, actively urging their governors and legislators to pursue expansion. They know they're missing out. That's also why even today, leaders in states that initially said no to expansion are trying to correct their mistakes. And yes, that's happening in so-called politically red states as well as blue states. In fact, 6 of the 22 states that expanded right away had Republican governors. 6 other states expanded through innovative style programs. And 7 additional states, only 3 of which have Democratic governors, are still trying to expand. I said from the beginning that once governors put partisanship aside and looked at the facts and saw what was going on in Kentucky and other expansion states, they too would want to help their people. Another important thing to consider is this. Kentucky isn't permanently locked into this position. If you look at the projected fiscal impact only, then you obviously see what a good deal that this is for the state. To see this, let's examine the next biennium, and that's reflected on this chart over here on my left. If you add the 2 years, the analysis clearly shows that the estimated additional expenditures from this decision over the biennium total $247.6 million. That's the sum of this line entitled Increased Cost, being the 74.4 and the 173.2. But the offsetting estimated value of additional tax revenue and savings from budget cuts and cost shifting from Medicaid expansion total $511.8 million. That's the line, if I can see it, that's the line right here with the subtotal. The $251.8 million in the first year, the 60 over there in the second year. And remember, these are conservative estimates. Now, we should monitor these figures, budget cycle by budget cycle, because the federal government doesn't require states that expand Medicaid to maintain that choice forever. Should future analysis in Kentucky reflect that the program no longer is affordable, the decision makers at that time have the ability to change the Medicaid program. But I bet those future decision makers will come to the same realization that I did, particularly because Medicaid expansion gives our healthcare providers the compensation they need for taking care of a population that was largely uninsured prior to expansion. So let's talk about the fourth positive impact of Medicaid expansion. That's the immediate influx of dollars to Kentucky's medical providers. Take a look at this next chart. Now, this is just for 2014. The bottom line, $1.16 billion. Medicaid expansion paid at least this amount in new Medicaid revenues to healthcare providers in calendar year 2014. That figure, I say at least, because it continues to grow as the bills incurred during 2014 are still working their way through the system and are being paid. Now, folks, this is cash on hand, new money in their pockets, money that would not have been there had they not expanded. You notice up at the top, hospitals got about $506 million of that $1.16 billion. Now, that's just 1 year. This study indicates that over the 8-year period, that figure, the bottom line figure there, is expected to reach almost $20 billion. That's almost $9.3 billion for Kentucky hospitals, $5 billion for pharmacies, $3.7 billion for primary care physicians. Now, you still hear some hospitals bemoaning the new landscape and talking about how they are being treated unfairly. Well, first take a look at these figures, and secondly, go find out for yourself. I'm going to give you 2 ways to do that. Last summer, our Cabinet for Health and Family Services produced a report that detailed the new revenues by provider and by county. The Cabinet has updated that report, and we're releasing it as a supplement so you can see in black and white the new revenues that providers are receiving. The second way to find out what's going on is what's called an online dashboard, or if you want to be formal and fancy, a Medicaid expansion utilization tool. There will be a link to this tool on the Office of the Governor's webpage, and our Health Policy Director will be giving a demonstration on this right after this news conference. On it, you're going to be able to find 4 categories of information. 1, the number of people enrolled in Medicaid expansion by county and broken down by all sorts of demographic information. 2, payments to providers broken down by county and by provider categories. 3, the number of preventive services provided, such as cancer screenings and cholesterol checks. And 4, the number of chronic diseases diagnosed in the Medicaid expansion population. We believe that facts help tell this story. And that's why we're making all of this information available to the media and to the public. But beyond the increased revenues, a second way in which hospitals benefit is a drop in uncompensated care cost. With fewer people lacking health care coverage, hospitals are being required to provide free services to fewer people. In fact, the cost of providing uncompensated care in Kentucky has dropped 60%, from $1.9 billion in charges in the first 3 quarters of 2013 to $766 million through the same time period in 2014. Yet, for the time being, hospitals are still receiving the full DSH payments of $199 million. These are the payments that partially reimburse hospitals for providing that care. These are scheduled to be reduced, but that reduction was delayed by the federal government until fiscal year 17. This represents, in essence, another huge pay raise for our hospitals. Now, let's talk about the health of our people and how better access to care has already begun to improve the collective health of Kentucky, especially when it comes to chronic problems like high blood pressure, diabetes, depression. After all, improving the collective health of Kentuckians was the whole purpose of this effort. That begins by getting people access to quality and affordable care. As you know, more than 500,000 people signed up through Connect for either Medicaid or a qualified health plan in 2014. Consequently, a Gallup poll this past year reported that the drop in the number of uninsured Kentuckians was second highest in the entire country, going from 20% in 2013 to under 12% midway through this last year. Look at these county maps. Here they are, right over here. Now you talk about a snapshot. Look at these county maps, which show our internal numbers for this drop in uninsured. The upper map, obviously, is the before picture, before the ACA. They're almost all orange. Now that I didn't pick that in terms of a state. But you can see the color of all of those counties and the legend up there that tells you what that represents in terms of the percentage of uninsured. Those uninsured numbers ran from the high teens up into the 20s throughout those counties. And look at the aftermath map. You don't see any orange. There's blue everywhere. Many of these are less than 5%. The blue, any blue, represents totals, uninsured totals of less than 10%. The number of uninsured Kentuckians will continue to drop as we enroll more people in Medicaid and connects qualified health plans. About 75% of those people reported not having coverage at the time that they enrolled through Connect. Folks, these are not aliens from some distant planet. They're our friends, they're our relatives, they're our neighbors. And thanks to Connect and the Medicaid expansion, they no longer have to choose between medicine and food. They no longer have to skip checkups and hope nothing goes wrong. They no longer have to ignore troubling signs like a lump or a pain and just hope and pray that it doesn't develop into a chronic disease or a fatal illness. And our children no longer have to go to school with painful toothaches or infected gums because they've never been able to see a dentist. Now, our friends and our family members can take full control of their own health. And indeed, they are. To gauge the demand for health care, Kentuckians who qualified for Medicaid expansion were compared with a baseline comparison group made up of some traditional Medicaid enrollees. The new enrollees in expanded Medicaid sought primary health care at a 55% higher rate than that comparable group. Not because they're sicker, but because they've been so long without health care. Talk about pent-up demand. And this care will have demonstrable and demonstrative benefits. Preventive medicine reduces the likelihood of chronic conditions developing. And regular screenings will help catch these conditions or diseases in their earliest stages, when they have the greatest chances for a positive outcome and are less costly to treat. Let's look at another chart on this side. Thanks to Medicaid expansion, and these are just some of the outcomes, and there are many more in your handout. In 2014, more than 90,000 Kentuckians had their cholesterol checked as a critical first step toward addressing heart disease. Almost 46,000 Kentuckians were screened for diabetes. More than 17,000 were screened for colorectal cancer. Almost 26,000 women received mammograms. More than 33,000 had cervical cancer screenings. And 80,000 Kentuckians had preventive dental visits. Now, why are those numbers important? Well, you and I both know why they're important, because controlling cholesterol helps prevent heart attacks and other coronary events. Regular mammograms reduce the number of deaths from breast cancer by as much as 28%. And when detected early, 90% of the people diagnosed with colon cancer, one of the most preventable forms of cancer, will survive at least 5 years, whereas the survival rate for late-stage colon cancer is significantly lower. Preventive care saves not only lives, but millions and millions of dollars. And for those already with advanced diseases or chronic conditions, Medicaid expansion gives them the ability to receive regular, ongoing treatment in the appropriate setting, not in their local emergency rooms and not having to depend upon the charity of local physicians. For example, we have 2,000 people qualifying for Medicaid expansion who are being treated for breast, prostate, colorectal, or uterine cancer, and 31,000 being seen for diabetes. Furthermore, in the areas of substance use and mental health, two of the most stubborn, long-term problems we have in this state, we have special potential to change the course of this Commonwealth's future. Since the ACA requires substance use disorder treatment to be covered as an essential health benefit, more than 300 new behavioral health providers have enrolled in our Medicaid program. Through Medicaid expansion, more than 13,000 Kentuckians diagnosed with a substance abuse disorder are receiving treatment, such as screening, assessment, medication-assisted therapy, outpatient therapy, and case management. They finally have a chance to get the help they need to lead productive lives. This preventive care is also a huge step forward in reaching specific health goals that we set as part of our Kentucky Health Now initiative. We started that initiative a year ago. As a matter of fact, it was a year ago next week, and it's chaired by Lieutenant Governor Crit Llewellyn. Through it, we're taking direct aim at stubborn health problems in 7 key areas, like tobacco use, obesity, heart disease, cancer, and behavioral and oral health. The preventive care made possible by Medicaid expansion will help us reach our goal of achieving those health outcome targets by 2019. Now, a few big picture things to think about. The authors of this report adopted a conservative view to guide predictions of future cost and health care needs. Because it's conservative, their financial models assumed that Kentucky's collective health wouldn't improve much. Essentially, that Kentuckians will continue to lead the nation in chronic conditions. But I think we already know that that's not going to be true, particularly because we're seizing an opportunity that other states have delayed. The opportunity which gives Kentucky an even better ability to improve our competitiveness and health profile relative to our so-called peer states. And this report also gave no value to the impact our growing economy will have on Medicaid populations. It doesn't take into account that as our economy continues to improve, some of our new Medicaid enrollees may get jobs that offer health insurance or pay enough that they no longer qualify for Medicaid. In other words, these figures I just shared do not count the societal impact of improved health on quality of life or on our economic capacity. Look, Kentucky has long ranked at the bottom or near the bottom in almost every health ranking, be that cancer deaths, heart disease, respiratory illnesses, substance abuse. The consequences have been devastating for our families and for our state. There is a direct line from poor health to almost every challenge that Kentucky faces, whether that's poverty, unemployment, low education attainment, substance abuse, or crime. I've said from the beginning that in order to improve our ability to compete economically, to compete for jobs, to compete for businesses, in other words, to improve our competitive capacity, and to improve the quality of life of our people in both the short and long term, we have to fix this weakness. Better health will have positive ramifications across the board in Kentucky, from improved productivity to better school attendance to a better public image. This report doesn't place a value on any of those benefits, but we know that they will be there. We also know that a stronger workforce will help us attract businesses and jobs to Kentucky. There are so many intangible, immeasurable benefits that accompany the tangible figures detailed in this report. So to all the naysayers who claim we can't afford expanded Medicaid, I say this. Everybody is entitled to their own opinion, but nobody is entitled to their own facts. And the facts are here, out clear and in front for all to see. Medicaid expansion is working, and it's paying off, literally. State and local governments are saving money. Hospitals are earning more. Our people are getting healthier, and our state is growing stronger. In short, we're changing the course of Kentucky's history, and we're creating a better future for all of us. Thank you. Now we'll take questions.
Well, you said that $819 million fiscal impact includes the cost of Kentucky assuming some of the costs starting in 2017. Is that correct?
The $819 million positive budget impact includes
Our state general fund share.
our state general, yeah. Yes, it does.
And why don't we have projections for fiscal 19 and 20?
They're in the
They are in the handout.
they're in the handout.
Oh, yeah.
We go all the way to 2021.
Yeah.
So,
And let me make a point about that. These studies are of necessity based upon facts and current numbers and then projections of what the future may hold. We are very confident about the projections in this report for the short-term future, for the next biennium, and even for the biennium after that. But obviously, as you get farther and farther out in time, it becomes a lot more relative in terms of all of the different moving parts that can change over a period of time. For instance, if our economy continues to improve, more people are going to have better jobs and are not even going to qualify for Medicaid even more. And what does that mean? That means the cost of the state will go down even more than is projected in these numbers. But all of those things are sort of what ifs, and that's why we recommend that as we move into the future, we take regular looks at this. We need to go back after another year and take another look at this and see what the second year's numbers are and confirm or see what the projections will be based upon then 2 years' actual numbers in this program.
this chart here where it talks about the estimated impact on the 17-18 biennial budget,
Okay?
it says increased cost, $74.4 million. Is that the match that will be required?
That's all the general fund money, yes, including the match that Kentucky will put up, isn't that right?
Yes,
74.4.
The 74.4.
And then the next year, the second year of the biennium, it's 173.2.
Okay, so that's how much the state match will be, I forget what the percentage will be. It's like-
Right.
It's
It starts out at 5%, and then it works its way up to 10% in 2021. I don't know exactly what years, the different percentages.
That's been the big question, right? Is how much
That's been the big
cost.
question that critics have raised about, can we afford to do what we're doing? And this conclusively shows that we not only can afford it, but quite honestly, we can't afford not to do this. I mean, when you see the positive economic benefits of 40,000 new jobs over the next 8 years, that's pretty hard to say no to. And what you see here is, yes, it's going to cost the state share, a total of, well, when you add those up, it was 240 something over the biennium, but that's offset against $511 million in new revenues and cost savings and all of the things that you add up. And so you actually come out over the next biennium with a total savings of about $264 million.
Governor, my question was about budget projections, and I can't find anything in these handouts for budget projections on FY 19 and 20.
Well, you make budget projections off of the projections that the forecast group gives you, and we'll be getting more budget projections that the next budget will be based on in November and December.
I think the question, though, is as the match goes up, and we would like to have a specific percentage year increases. In 2020, we're going to be paying 10% of this, and there's no budget projections for fiscal year 19-20. We don't know if it's going to pay for itself in those years, do we?
Well, Deloitte says it will.
And they don't have specific figures to say that.
In the white paper.
Yeah, the full paper's got those numbers in
All
there.
right, okay.
They're in there.
Yeah.
Yeah, well, we did not receive that.
You don't have the report?
They don't have the 75.
It's not in the
It's
handout.
online.
Oh, okay, it's on, okay.
Online.
The full report is online. You can access it, and what, do you remember which chart that is? So
It's
that,
on
It-
page 59.
yeah.
Page
Table
59.
23.
table 23.
And the match rates are on page 18, table 2.
Is Kentucky still facing a physician shortage?
That depends on how you define shortage. I think if you take our population and take the number of physicians, you probably come up with one answer, that maybe we don't have much of a shortage. But when you see the geographic locations, then that causes some concern. But part of what we're doing at the same time is that we're expanding health care for people, is that we are pushing all the different provider groups to make sure they're expanding to the maximum their ability to provide services, whether
Open
that's
license.
physician's assistants or nurse practitioners or doctors. You know, there's a number of providers that we're going to be needing to call on as we move forward to help us take care of people and help us to provide the services. I think what you're going to see is an influx of people going through the training necessary to become one of those providers, or people coming here because here they can get paid for what they do, unlike in a lot of these other states that haven't expanded yet.
Just to follow up on Al's question, just so I'm clear, do you recall what the amount of the budget line was for Kentucky's share of the Medicaid reimbursement before ACA? I have written down 1.3 billion from previous notes. I don't know if that was correct or not.
I'm sorry, what's the question exactly now?
What was Kentucky's share? What was Kentucky's cost?
Had we not expanded?
You mean just regular Medicaid?
Before.
Right, before ACA even existed.
In other words, just how much in the budget does Medicaid cost the state?
Right. And how does that? And then what's it going to be then after this in terms of total line item on?
The Medicaid budget, federal and state, so I'd have to rely on some folks from Medicaid to tell you it's 30% is the state share of old Medicaid. Was about $6 billion in 2012, around 2012.
Per year? Or is that a two?
That was per year for 1 year. That's the federal and state combined. And of that, that was right about the time we went to managed care. So about 150,000 of those people equaled about $3 billion of that budget, because those people are in specialized waiver programs, their complex medical needs, their long-term care in nursing homes. And about half of that budget was our managed care budget, but was about 650,000 or 700,000 people, as I recall the number when we expanded. So that's what it was at that time, federal and state. We can get you those exact numbers. We're happy to.
I guess, and you may have already answered this at the table that you gave before, was basically the next governor, what will that line item be for Medicaid and his budget?
Well, we know that it will be 74.4 plus 173.2 more because we've expanded Medicaid.
But the old line isn't exactly the same either, because there are savings that have accrued that are counted in here as well.
I do think that's an important point. Once that you begin to look through the white paper, you will see charts of where there were things that the state was paying for in behavioral health, in public health, and other areas of government that now is being paid for by 100% federal. And even in the future, some of that will be picked up. I think one of the benefits that we should not underestimate is that now we have substance abuse treatment. And we know all of your papers and news outlets have reported on it regularly. And, just because we have substance abuse treatment doesn't mean that people who are abusing wake up the next morning and say, wow, I think I'm going to go get treatment now. That's just not how life works. To have the numbers that we're reporting, distinctly different individuals, I think it's 13,000, that are actively screening, assessed, or in some stage of substance abuse treatment, that is very good for our state. Because that not only affects the individual, that impacts a family. We want these people to become active citizens and back into the workplace. And so it impacts all of our cabinet. I think people don't understand sometimes when they think about substance abuse, the one individual impacts our justice system. It certainly impacts community-based services or social service system, the strain on that system. So it has far-reaching impacts on government. This is a big deal.
If after you've added in the woodwork, in terms
Well, our old, what we're calling traditional, we started calling it old, and then we thought that sounded kind of bad, so we're calling it traditional. Our traditional population, once we add in the woodwork, it has been relatively stable. We have a regular churn of about 25,000 people a month, believe it or not, in and out of the system of our traditional Medicaid population every month. So one of the things we're going to be watching in this coming year especially is what is the churn from Medicaid expansion as people get healthy and can return to work and more jobs become available. What is the churn from Medicaid expansion to a qualified health plan? So I think that this is the earliest glimpse and look back of the first year of any state that we are aware of. And so there are definitely more analysis that we'd like to do to learn sort of the habits or the trends of the expansion population.
Governor, I asked this question somewhat tongue-in-cheek, but do you think this is going to end the argument over the Affordable Care Act in Kentucky, especially with all the people running for your job right now?
Well, what I want to do is simply this. People can have whatever opinion they want, but they aren't entitled to their own facts. And I hope you in the news media this year, when you are interviewing and questioning all of the candidates for governor on both sides of the aisle, that if they start making these wild statements about how bad this is, at least you have the facts here. And they need to address the facts. It's one thing just not to like it because the president has his name on it. And if that's the reason that they want to take health care away from 500,000 Kentuckians, I mean, then that's their opinion, and people ought to know that. But, where we are today is that we have answered the questions, number one, will it work? Because it's working in Kentucky. And number two, can we afford it? And yes, we can. So, having said that, then I think the answer that all of these candidates, the question that all of these candidates have to answer is, okay, we know we can afford it. It is working. So, do you want to take affordable health care away from 500,000 Kentuckians? If you do, then okay, that's your opinion, but people ought to know that. And if you do that, what are you going to replace it with? How are these 500,000 people going to have affordable health care if you shut this program off? So, that's a very good question for you guys to ask as we go through this year, and let's see what the answers are.
Governor, I think most of the Republican candidates have said they would keep Medicaid expansion.
Very good.
They would get rid of Connect instead.
You mean the award-winning program? They'll get rid of that one.
Because they're saying that there's a federal website that they could use, and we don't need to spend $40 million or whatever the state-run website. Do you think the state-run website is crucial to making this work?
The state-run website, number one, it doesn't cost $40 million.
No, and it is more than a search engine, I might add, or
More than a website.
More than a website. The other thing that is so crucial about this website that we have is that today we have much better controls on fraud in many other areas than we have before, because when you sign up for Medicaid, everybody, the traditional population as well as the expansion, we are enrolling everyone sort of through the website that was created known as Connect. And what this means is that on a regular basis, that we ping individuals that are on Medicaid to the federal website to be sure that they aren't earning more to make them ineligible, that they are who they say they are, that nothing has changed in where there is a federal form that has gone in to change their status that would make them become ineligible. We actually know more about the population now than we have before, and have better controls, and they will become better. The other thing is that this website now has given us in the cabinet, in the not too distant future, we're going to be able to finally look at families holistically. We're going to be able to, all of our websites are going to almost in the back version, sort of in the back end of them, we're going to know which families that are on Medicaid are also receiving food stamps, are also receiving TANF, and so forth. When that happens in the next several months, that all of these become intertwined, I mean, we are the envy of many other states, because the potential for us to really focus on lifting these families up out of poverty in so many ways and really focus our energies for them is pretty miraculous. And this website has given us an opportunity to build off of it and improve so many of our IT components of this cabinet. It's pretty incredible.
With the deadline to enroll this weekend, any estimate on how many Kentuckians still don't have insurance and will be subject to the IRS penalty?
No, but you should come to the Connect store tomorrow, because the governor will be hosting a press conference there to talk about the end of open enrollment. But the other thing is that if you are Medicaid eligible, you can enroll anytime for Medicaid. It doesn't end on February the 15th. Also remember, if you have a life-changing event,
But is that still the deadline? Like if you're not enrolled in Medicaid and you're eligible after February 15th?
you can enroll on the 16th if you're
You'd be
eligible.
subject to a penalty if you don't earn? Is that
No,
still-
no, no. If you're eligible for Medicaid, you aren't subject to a penalty.
How many have signed up so far in the current enrollment period?
For Medicaid, the current enrollment, I'd have to look back. As of February the 1st, we have about 388,000 people total. That's part of Medicaid expansion. Yeah.
However, you mentioned the huge pay raise that you put at the hospitals have gotten as a result of the increased revenues from the Medicaid funds. What about the costs that the hospitals are incurring from taking care of a lot of people who are coming in for, as you put it, some of the deferred treatment we had in the past?
They're getting paid for that treatment now. That's what this $1.16 billion is all about, is that before, they were still providing that care to all of these people coming in, but they had no way to bill anybody or collect for it. And now, because the people coming in are covered by expanded Medicaid or by a qualified health plan, they're actually able to bill and get paid for that. So they're finally getting paid for the work they do. That's why hospitals and other providers are so much better off today. And it's not just anecdotally that I know that. You have a list. Did we put that list in their packet of every hospital and the?
It's going online. We have, this is.
Oh, it's okay. It's online.
The report.
Every hospital in the state, and how much more they are receiving for what was previously uncompensated care. And some of them, it's like 50%. It's,
Is there
it,
any study though that asks them or tries to find out if they have increased costs related to implementing the system?
You know,
you mean they've had to buy more machines
Or
or?
whatever, I mean, I would.
well, first of all, a lot of this is preventative care, as we know. People that are finally taking their medicine for diabetes and many other things. However, even though Medicaid is admittedly the lowest payer, so you have private insurance and then Medicare and then usually Medicaid. We pay somewhere between 75-78% of Medicare. However, that is better than getting zero. A lot better. It's 75% better than getting zero for that same treatment, which they were getting before. So I would say that's a good thing. And I don't know about you, but the last time I looked at a bill, I was having a hard time reading it. I mean, we've seen many studies where does something cost $2,500 at one place, $2,800 at another? I mean, in different places around the state, different services are going to cost, obviously, different amounts. But I believe that in most cases, I won't ever say ever, that our providers are being fairly reimbursed. Would they like to have more? Well, of course. But we compare ourselves to other surrounding states and our Medicaid reimbursement on a regular basis, and it is a very fair rate.
When you say you pay about 75%.
75 to 78, yes, usually,
Of Medicare.
of Medicare.
Oh, okay, that's not the percentage of the bill cost you're talking about.
No. So whatever Medicare pays is usually what both private rates are they're a baseline almost in the healthcare industry and the insurance industry. So 100% of Medicare is, and generally the private insurance market pays a little above usually the Medicare rate for reimbursement.
And what's that percentage on average?
It's according to the service. Yeah. Yes, Robin.
The recent consultant report had, we pay 93% of Medicare. Commercial normally pays 125% of cost. And Medicare.
Well, excuse me. We were paying so much more than I thought.
93% of Medicare.
Right.
About 75 to 78% of cost.
Of cost, yes,
And that's
okay.
based on
Thank you.
something KJ sent us.
Thank you.
Well, and the point she was making, I think that we need to make sure is clear as the word cost. Just get the last bill that you got if you were ever in the hospital, and when you start down that bill and you had a broken arm and got it fixed, and at the top is $25,000, and then by the time you get all the other numbers and everything, you pay the hospital $918.25. The whole cost game is so out of control in the healthcare industry, and I'm not blaming it on the hospitals. They have to play the game, but the word cost has very little relationship to the actual cost that they have of delivering the service.
Governor, if I could anticipate what some of these Republican candidates are likely to say, it would be that, sure, this is a study, it's paid for by the state, which wanted certain results, and it's largely projections, it's not largely facts. What would you say to that anticipated statement?
Well, first of all, I would say that when you have PricewaterhouseCoopers and then Deloitte Consulting, two internationally known and highly reputable firms, do your studies for you, that they are about as reliable as any study can be. That includes not only actual numbers but also projections. And secondly, I would say, you're simply looking for another excuse. Look, these are the facts. These are as good of facts as you're going to find in this area right now. Next year, we'll have another set of actual numbers, and we can take another look at this. But I'll predict to you that it'll look at least as good, if not better, than what these numbers look. Because we know enough now to know that economically, this is going to work. I mean, and it's going to be a big plus for the Commonwealth of Kentucky in terms of future economic impact and future jobs for the state. Even more importantly, it's going to be an extremely positive impact on our people. And the fact that for the first time in our history, they can go to the doctor and stay healthy, and they can take their kids and stay healthy. And the long-term impact of that is immeasurable, because when you've got a healthy group of people here, you got a healthy workforce. When you got a healthy workforce, you got a productive workforce. When you got a productive workforce, you're going to attract all kinds of businesses and jobs to this state. So there's so many good, positive results that'll come out of this. And people ought to embrace it. There's nothing wrong with Kentucky doing a lot better than it's done in the past. There's nothing wrong with Kentucky being a lot healthier than we have been in the past. That's all good, and it's all non-political. It doesn't need to get into the political realm. I mean, we're all Kentuckians, and we all want this state to do well, and we ought to join in and embrace a situation that is going to make us do better.
And Al, if I could just add to the governor's comments, you know, this is one of the biggest public policy decisions that's been made in the history of the state, for the governor to embrace these health care reforms, to expand Medicaid. Prior to that, moving to managed care in Medicaid, which was fundamental to our being able to sustain the program. And I think when you make a decision like that, you have to recognize there will be questions asked. There will be criticisms. I think this administration, and I'm not claiming credit because I wasn't here as part of this decision, but when this administration decided to get an independent analysis before they made the initial decision, and now, 1 year in, with an independent look at real numbers, there's no stronger step this administration could have taken to lay out the case for how this is working. And as the governor said, I think we would all recommend that this be done in an ongoing way moving forward. Because you need that kind of outside look. This is a major policy decision. It has long-term implications for the state, and we need that other pair of eyes giving us this type of analysis. And back to your initial question you had about the budget and the relationship to the budget, this step today is prior to the budget process. This is valuable information now that'll be put in the hands of the budget office and as well as the consensus forecast group, because we're at the early stages of pulling all the numbers together that predict how a budget gets put together. But that will be a step that will now be able to incorporate this analysis, and it'll provide invaluable data going into the budget process.
How much was Deloitte paid for this?
You know, I should have looked that up before I came. We are happy to get it to you, and I would tell you what I think it was, but I'm afraid I would be wrong. So I would just say that Jill will make sure we let you know that, and anyone else, just make sure that Jill knows that you want that this afternoon. We're happy to email it to you. I should have looked that up. Shame on me. I should have anticipated.
I think what we ought to say in conclusion is that this Deloitte report is almost as reliable as an audit conducted by then Auditor Craig Llewellyn. That puts it on about as high a level as you can put it on. Thank you.
You all stick around, we'll demo the dashboard that we're recording